Good morning, everyone, and welcome to session 2 of our Arizona Cancer Registry 2025 Annual Educational Workshop. And I'm just going to go over a few bits of housekeeping before we get started with our first presentation of the day. So as a reminder, we have been approved for 8 CE hours by NCRA, of which 2.75 are designated Category A CE hours, including the GYN presentation. I've heard no sound. Can anybody hear me?
I can hear you, Juliet.
Okay, thank you. Stephanie, you might just want to check your sound settings. And I'll type that since I bet you can't hear me. So this workshop does not qualify for CEIP credit because it is not in person. But we do have 8 CE hours available for you at the end of the workshop if you attend all 4 sessions. And you should have received the CE tracker where you can mark down the sessions that you've attended and keep track of that. You'll be sent a CE certificate of completion after session 4 that you can fill out with the number of CEs that you have earned. And if you're looking for CEIP hours, we are planning to offer an opportunity for CEIP education in December. So keep your eye on your email inbox for that, because I'll be sending out more information very soon about that opportunity coming up. So next, here's our agenda for today. We are right in the middle of the welcome, and then Michelle Lenzen, our QA manager, will be presenting on quality assurance projects and updates. And that will be followed by my presentation on site-specific abstracting for GYN cancers. And at the end of today, we'll have a formal Q&A session. So make sure that you get some good questions together to put us on the spot. We do have 2 different chats. And there's the regular chat, which we want you to use for general questions and comments, communicating with one another, and technical questions. If you're posting in that chat, be aware that everyone can see that post. So we ask that you're respectful, professional, and thoughtful, which I know you all are. So that is the chat. We also have the Q&A chat, and we want you to use that for questions related to today's sessions. And we'll be answering all of the questions from today's presentation at the end of the day during the formal Q&A session. So be as specific as possible with your questions. And any questions that we don't get to during the live Q&A, or any questions that we need to research a little more, will be answered in a Q&A document, which is going to be sent out following the workshop. If you've attended our annual educational workshop prior to this, you know the drill. We'll be sending out all the questions and answers together at the end so that you're able to review Q&A for all 4 of the sessions. So that is all the housekeeping that I have for today. And I am going to turn our first presentation over to our QA manager, Michelle Lenzen. So Michelle, whenever you are ready, I'm going to stop sharing so that you can share your screen.
Thank you. Let me see here. Bear with me, guys. All right, how's that look?
Looks great. I can hear you and I can see your slides.
Okay. Oh my goodness. So I want to apologize in advance, everyone. I redid my setup for this so I could face you guys, and now it's kind of not being cooperative with my layout. So I'm going to turn my video on. Even though it's displaying over here, I'm right here. Hi, you guys know me. My name is Michelle Lenzen. I'm the QA manager. I've been with the Arizona Cancer Registry since 2018, and you've probably interacted with me in all different kinds of capacities. So today, I'm going to be giving you some updates on some of the projects that we worked on this year and some other little QA items that I normally go over with you guys. So give me just a minute to bring up my slides here. Okay. So here's my outline. I'm going to touch on a few things. One of the big things I want to touch on is going to be edits. I'm also going to talk about software conversions. And then again, like I said, a few of the bigger QA projects that we've had going on this year. So let's start off with ACR edits. So this is just a summary slide of what I mean when I say I want to talk about ACR edits. I'm referring to our state-specific meta file that we generate every year for our hospital registries. And so every case submitted by a hospital to the ACR has to pass the most recent ACR meta file for the version of their software that they're running. So like I have in the example on the slide, let's say that you're running a V25 version of your software, you would need to have our ACR V25B1 edit package incorporated into your software and would need to run those edits on all cases submitted to us. So we send blast emails out every time a new version of our edit package is available. And vendors typically get notified first, and they can get our edits on the NACER Edits Clearinghouse. But we also post them to our website for hospitals to download as well. So the picture in this slide is actually of the edit detail report that I create when I generate the meta file. And it actually comes in really, really handy when you get stuck trying to fix an edit, because this document actually includes descriptions of every edit in our edit package. And sometimes reading the description of the edit and what it looks at can be really helpful when you're trying to troubleshoot an edit error. So the link that I have at the bottom of the slide actually takes you to our webpage where you can find both the meta file and this detail report. So let's talk about what's new in our ACR edits for 2025. Not a lot of changes, honestly, this year, but there are two new SSDIs that apply for 2025 forward. So you have NACER item number 1174, which is PDL1 for lung, and you have number 1172, which is PTLD for certain heme schemas. So we have some edits that we've added that make sure that those new data items are coded as required and coded correctly. So as you can see in this slide, each new SSDI will have an edit that checks to make sure that the SSDI is only coded for 2025 forward, and that the code entered for the SSDI is not the not applicable value or not left blank for that data item, because they're both required by the ACR. So I think these types of edits are usually a good idea when we introduce a new data item, because you guys aren't used to having to code it, so the edit kind of acts as a good reminder. So there are also two new AZ custom edits in V25B1, and they just make sure that date first contact and date last contact are not left blank and are complete dates with the month, day, and year coded. So we started noticing that these two particular date items are sometimes left either completely blank or filled in only with partial information. And these two date fields are actually really, really important and have always been required. We just didn't have an edit that checked to make sure that it wasn't blank, or it might have allowed for partial dates for several years. So we actually use these dates for timeliness and completeness and for other metrics and statistics. So it's really, really important that they're always coded and are entered as complete dates. Okay. So cancer path chart. I went really in depth with this last year, so I'm not going to do that to you guys this year. But I did put at the bottom of this particular slide, you can see I put a link to the ADHS YouTube channel where that presentation is, and I actually put a timestamp on there for when I started talking about path chart, if you want more detail on what path chart is and what it does. All I really wanted to do with this slide was just continue to remind you that the site histology validity edit that's in our ACR edits points to this path chart table, starting with diagnosis year 2023 and forward. and the number of combinations that are in that table increases every year. So you can kind of see what they've been doing with that implementation timeline chart that I have there on the right. So that means there's going to be instances where certain primary site and histology combinations that used to be allowed with an override flag won't be allowed and won't pass this new edit. So just use your resources, including CPC search, which I've also linked in this slide, as needed, and just make sure you're assigning the correct primary site and histology for your cases. We don't have a base 2026 edits meta file from NACER just yet, so I can't for sure tell you what's going to be in our V26 ACR edits, but I can make a few guesses based on what we've seen in the 2026 NACER implementation guidelines so far. So I would say to expect that cancer path chart will be fully implemented for 2026, and that you'll see additional primary site and histology combinations added to that edit that we already have that checks for the validity of those combinations. And also expect an edit that checks for a new data item, NACER data item number 225, sex assigned at birth, which is going to be replacing NACER data item 220, sex, for all cases, regardless of diagnosis year, starting in 2026. And also expect it's either going to be a new edit or a current edit that's in the meta file that looks at the SSDI for MSI. It looks like they're expanding that to be required for more schemas. So you might see an edit pop up if you don't code that data item for those new schemas in 2026. Oh, software conversions. Okay. So I thought we would talk a little bit more about software conversions. It's become a yearly occurrence at this point. So I just kind of want to make sure you guys understand what we do at the central registry for our conversion, and a little bit more of what we need from you all when you guys convert at the hospital level. So let's talk about our timeline first. So we actually start prepping for conversion the year prior. So we're actually doing this right now. We're getting ready for our data submission, and we're doing this at the same time. So we're reviewing requirements from standard setters and planning our new version of our edits meta file. And then once our data submission is over towards the beginning of the new year, we start prepping all the materials that we distribute. So, Juliet's working on the ACR coding handbook and the required data items list. I'm working on the meta file, etc. Those materials normally get completed by May of that year, and then we'll send out some blast emails out to all of y'all and also to your vendors to kind of let you know where to find those items. We then usually convert our own central database in early June. And again, we send out notification to everyone when that conversion is complete, and we let everyone know that we can start accepting cases in that new version of the software. And then in July, we start that process all over again for the next year. And we try really hard to keep you guys updated on what's going on in our newsletters and give you previews of changes in our annual workshops like we're doing right now, etc. So what do we need from you guys? The biggest thing is just try to let us know when you're planning to convert, and really be careful about accidentally abstracting new diagnosis year cases in an old version of your software. So doing that can actually cause a lot of problems and lead to those cases being incomplete and getting rejected by us when you try to submit them to the central registry. So this actually has been happening pretty often. And to help with this, NACER actually created a new edit that we've adopted into our meta file that doesn't let you abstract a case if your diagnosis year is newer than your software version year. So for example, you wouldn't be able to abstract a 2026 case in a V25 version of your software. You would need to convert your software to V26 and then abstract that 2026 case. So I would also say just some of the things that you can do to help us when you get ready to convert. Keep copies of all those blast emails. We try to communicate with you guys as much as possible, keep you in the loop as much as possible. So those emails will come in handy. They'll have instructions and information that you will need at some point. Also, lastly, not required, but we do recommend that you try to finish the bulk of your current diagnosis year before you convert. So like my example in the slide states, finish, your diagnosis year 2024 cases in V24, then convert to V25 when you're ready to start your diagnosis year 2025 cases. Like I said, it's not absolutely required, but we kind of just recommend it as best practice. So what about after you convert? Well, again, just let us know. I would say get into your software and look everything over. Make sure all your required data items are displayed correctly. Make sure you have the most recent version of our edits, and definitely follow back with your vendor right away if you notice any issues. Make sure you have all of your needed resources from us and from our standard setters for the new diagnosis year. And again, keep those blast emails handy because they will probably have answers to most of the questions you might have after you convert. Now, should something happen where you need our help, there's always someone here to help you. So I kind of tried to break down who to contact by the scenario. So any questions about edits, those would go to me. I'm happy to help. Any questions about your submission file would probably go to Rayanne, was a good place to start. And then any coding questions about the new diagnosis year and new requirements, those should go to Juliet. Okay, so let's talk about two of the big QA projects that we had going on this year and the results. Okay. So the dreaded death clearance project. I know every year I send you a long-winded email with a bunch of instructions, and then you get this huge report and a deadline. So I wanted to talk a little bit about how great we've actually been doing with this project for the last few years, just to make you guys feel better. So a quick reminder about what death clearance is. So the Central Registry links with Arizona Vital Records every year to update our database with death information for cancer patients who have passed on that year. Okay, and this information is vital for calculating survival statistics for Arizonans and to better understand our state's cancer burden. Well, when we perform that process, we inevitably find death certificates with a cancer diagnosis coded as a cause of death, but that doesn't match to a patient in our database. And we are required to perform follow-back on those death certificates to look for missed cases. So we do a lot of things to do that follow-back process. We do visual review of those death certificates. We generate reports for you after doing an additional linkage to your hospital discharge data. We also use the Arizona Health Information Exchange, or HIE, as I'm going to call it, to try to abstract those missing cases internally. So all of this work hopefully leads to us getting our DCO rate. So when I say DCO rate, that is the percentage of cases in our database for a particular diagnosis here, where the only source for that cancer information is a death certificate. We try to get that rate to be under 3%. So how did we do this year? Really well, actually. So we started with roughly 2,500 DCO records that required follow-back. We sent about 2,000 of those records to you guys in your death clearance reports. And as you can see from my slide, over 1,300 cases have come back to the Central Registry as a reportable case from those reports. So the remaining cases that weren't sent out in the reports were looked up manually in the HIE to help perform follow-back internally. And we also used the HIE to review any case that came back in your completed reports as non-reportable by your facility. So, and you can see from my slide what we were able to do internally with those cases. So we completed this process last year as well, and we ended up having a DCO rate of just 1% for our 2024 submission. And I'm happy to report we actually just finished this process yesterday, so I'm sorry I didn't have a chance to update my slides, but it looks like we're going to be sitting right around 1% again this year. So that's really great news, and it's a lot of hard work from all sides that made that happen, so I just want to say thank you. Okay, so another big project we worked on this year was a resubmission audit for diagnosis year 2023. We started this project in March, where we reviewed our overall 2023 completeness, for 2023 by running case counts by diagnosis year for all our hospital reporters. And then what we did is we focused only on hospitals that were already submitting 2024 cases, but had 2023 case counts that were significantly lower than their 2022 case counts and were lower or far below their 5-year average case count. So out of all the hospitals that we reviewed, 10 hospitals were ultimately selected to resubmit all of their diagnosis year 2023 cases. Now, initially, we thought that we estimated we would find about 1,900 cases in total from this process. So how did we do? Well, and what did we do? Actually, let me tell you what we did first. We ran them through a linkage process with our central database and compared what we already had in our system from each facility to what was in that resubmission file from that facility. Then we added any cases that were identified as missing to our central database, and we provided the hospital with our findings and a listing report of those cases that were added. We also ran some queries and some frequencies in our system to see if we noticed any trends that might help explain why those cases were missing in the first place. And then we communicated those findings back to the hospital as well. So you can see over 1,000 cases were added to our database for 2023 from this project. So not quite the 1,900 that we thought we would find, but still pretty good. And I think that's all I have. So Juliet, I might have gone through that a little quickly. But if anyone had any questions, please place them in the Q&A. I can answer them live at the end of the session, or I can also provide an in-depth answer in the Q&A document that we issue at the end of all sessions. And I just wanted to take a minute and say thank you for everybody who's attending today. I know that some of the things that we talk about in the projects we send your way are tedious and they are time consuming, but I hope me giving you some updates and some numbers helps you understand how important your help is in us doing what we're required to do as a central registry and how important that work is. So I just want to say it's a pleasure working with all of you, and I want to thank you for everything you do.
Thanks, Michelle. We do have a couple of questions for later, or if you want to, you can answer them now. Totally up to you.
Let me see. Hold on. Let me see if stopping sharing gets my screens back in order. Okay. Here we go. Okay. Is it okay if I answer them live since I'm a little too fast?
Absolutely.
Okay. Right. So Candy, yeah, if you look at what the new data item will be, Candy's asking sex assigned at birth. Does that mean that there is no code for intersex patients? From what I understand, it's going to be assigned male at birth, assigned female at birth, and unknown. And Juliet, please correct me if I'm wrong.
No, you're correct. I actually just looked and there are some notes if you go to the NACER data dictionary on that item that instruct you that in those situations you would code a 9 if the patient's sex is not clearly defined or if the patient is born with any disorders of sexual development, or if the patient's sex is documented as other than male or female, for example, non-binary, transsexual, anything else. And there is no additional information about sex assigned at birth. So that is the new data item, and those are the options they give us.
And it's so also that being said, it not only replaces data item 220, which is sex, which is what we've been coding, but I believe when we convert to V26, they will be converting that 220 value to that 225 value, and a conversion will happen there as well. Okay, so we have another question. Given that we have so many snowbirds, winter visitors is what we call them, how does residency affect the death clearance report? So the death clearance manual does address these types of things. Sorry, the mailman's here and my dogs are letting me know. I'm just going to talk over them. So we are only required to do certain things. So we are required to look at Arizona residents and people who died in Arizona. So no doubt there are most definitely going to be instances, and I will say from working in the HIE, I discover death clearance records all the time where the patient was not actually an Arizona resident and they were diagnosed. In those instances, what we try to do is correctly assign the state of residence when they were diagnosed and treated, and make sure that that particular state gets that death information when we do our inter-registry data exchanges. But yeah, that Arizona definitely, I would say, there are a lot of instances where when we do that linkage and look at those death certificates, that was not an Arizona resident at diagnosis. Okay, Candy. Okay. All right. And Candy, I think the next part of your question, we might want to look at that a little bit more and answer that in the Q&A that we issue after all sessions. And Rose, thank you. Yeah, I definitely, Rose, so there's a question. It sounds like sex is going to be a lot of unknowns based on the information Juliet just shared. Honestly, I can't give you an honest answer about that until we have a chance to look at what the conversion does to the current sex data item that we're doing. And once we actually start seeing cases come in, but that's definitely something that we're going to keep an eye on. Thank you. All right, I think I got all of the questions, Juliet, so I'm going to mute myself and take myself off camera and send it back to you.
Looks like it. And obviously, if you guys have other questions for Michelle, continue to put them in that Q&A chat. And that way we can get to them at the end after my presentation. Keep the good questions coming. And I also wanted to mention that I did put the link to fill out the evaluation for today's workshop in the chat. We really do appreciate if you take time to fill that out and give us some feedback, because we want to make sure that the information we present here and the education that we offer is valuable for you guys as you are going through your abstracts. We want to make sure that you have the tools that you need from us in order to feel comfortable and confident coding these data items with all the constant changes. As we all know, our field is continuing to develop, and so we've got to stay up to date with what we need to be doing when we're abstracting. So Q&A chat is still open for any questions you have. And as I said, please do take some time to open up that link and fill out the evaluation. We decided to start doing that per session just so that we can give as many people as possible a chance to give us feedback, and so that you have the evaluation as we are going through the presentations and you can really have a good sense of how you felt about these presentations. So thank you in advance for doing that. I'm going to go ahead and share my screen, and then we can talk about coding GYN cases. So give me just a moment. All right, you should be seeing the title slide for my presentation, and we're going to spend the next little bit talking about coding GYN cases. So that's what this presentation is about. I want to go through our objectives just so that you can keep me on track as I'm presenting. I'm going to be talking about the anatomy of the female reproductive system, and I'm going to be describing coding grade and staging for GYN cancer cases. And I'm going to be focusing on ovary, fallopian tube, and the female peritoneum, because if I were to include uterus, then that would be a much longer presentation. And so I will be doing a separate uterus presentation at some point. But when I say GYN today, those are specifically the sites that I wanted to take an in-depth look at. And I'll be talking a bit more in a little while about why peritoneum gets classified with these other GYN malignancies. And so that's why those are the 3 subsites. And then I want to summarize coding of required GYN site-specific factors. I want to talk about current treatment practices for GYN cancers. And then we've got some pop quizzes and some coding scenarios we're going to go through to help us really get some practice talking about how to code these cases, which, as I know, can often be challenging. So I'm going to start out with anatomy, and then there's my reminder that we're not covering uterus today, but I will at some future point, especially if you all want more about coding uterus primaries. So here's our general overview of the female reproductive anatomy. And you can see that where number 1 is, that's the ovary, one of the 3 sites that we're really going to focus on today. Then we have the infundibulum, moving into the fallopian tubes, which are number 3. And the uterus is just beneath that. 4 and 5 is our cervix, and leading into the vaginal opening. So when we talk about the female reproductive anatomy, we're really talking about sites that are located in the true pelvis, because as you can see, 8 is the pubic symphysis, and bordering on the posterior side is our sacrum and our coccyx. And so that's the area that we're really focusing in on today. And you can see that when these cancers spread, they tend to go widely disseminated throughout the pelvic region. So you've got the urinary bladder right there, that's number 7, and the urethra, those would be our urinary primaries that we're not covering in depth today. And again, posterior to the female reproductive anatomy are segments of the colon. So when we're talking about staging, all of these organs that are nearby the ovary and the fallopian tubes can have the potential to be impacted, especially as these cancers spread. So there is your overall big picture glance at the area of anatomy that we're talking about. And ovarian cancer really spreads through shedding malignant cells into that abdominal and pelvic cavity. So the adjacent tissues and organs, such as the peritoneal wall, the pelvic side gutters, the liver, the stomach, the intestines, the omentum, and the diaphragm, can show up as extra ovarian tumor implants in any of those areas. And sometimes I've seen cases, and there can be cases, where those tumor implants can regress as well. So I spend a lot of time when I'm abstracting these cases looking at the surgical reports to really see where they found these tumor implants. And non-invasive implants can also show up, and they're classified as desmoplastic or epithelial. Obviously, those patients have a better prognosis than those that have invasive tumor implants. And those invasive implants are associated with invasive carcinomas. They can also be seen in low-grade serous carcinoma or seromucinous carcinoma as well. Peritoneum, that site gets talked about a lot, and I wanted to take a minute while I'm going through this anatomy introduction to really give you an idea of what I mean when I talk about peritoneum and retroperitoneum. So the peritoneum is closed sac within the abdominal cavity, also called the peritoneal cavity, and its function is really to support abdominal organs. And there's that space between the parietal and the visceral peritoneum as well. In females, the peritoneum is perforated by the ends of the fallopian tubes. So as you're looking at the left-hand side of my slide, you can see that there are 2 main portions of that peritoneal area, that peritoneal cavity. The red on that slide indicates the main cavity, also called the greater sac, and you can see how many organs are really bordered by that peritoneal area. And then the blue indicates the lesser sac, or the omental bursa. And you can see that a lot of the abdomen and the pelvis is covered by peritoneal tissue. And those areas that are covered completely by the peritoneum or are considered intraperitoneal are the ovaries, the liver, and the transverse colon. So that's the relationship, part of the relationship between female reproductive anatomy and the peritoneum, and why so often we see these cancers show up with peritoneal implants, because it's all right there anatomically connected. And primary peritoneal tumors in females behave a lot like ovarian tumors. And I've got a slide later that's going to hopefully give us a lot of good information about how physicians can tell the difference when we're trying to look at and code primary site, because it can be tricky when the peritoneum is involved to figure out if that started in the peritoneum or if it started as an ovarian primary. And of course, in patients who are male, the peritoneum gets coded differently. But for females, peritoneum and the way that they treat peritoneal carcinomas is very similar to how they treat primary ovarian cancers, which is why I wanted to include that. So what do we mean when we're talking about retroperitoneum? Well, if we go back to our Latin roots, retro is behind or posterior to the peritoneum. And I've got an image on the right side that shows you the retroperitoneal space. And there's a whole lot of room there for cancers to spread retroperitoneally. And because of that, these can get diagnosed later because it just doesn't show up. There's so much room that some of those symptoms don't lead to a diagnosis until later on in the disease process. So retroperitoneally, those organs that have their anterior surface covered by peritoneal tissue would be the aorta, the IVC, the kidney, and the adrenal glands. And you can see that retroperitoneal space is broken up too. There's the anterior pararenal space, so the area that is in front of and bordering the kidneys, the pararenal space, that area that's right near those kidneys, and then the posterior pararenal space, that area that is behind the kidneys. So that's the retroperitoneum. And hopefully our physicians do a really good job at telling us where that tumor has spread to, but it can be tricky. So we've got to be checking the op report as well as the pathology report. Next slide. So here is the ovaries and the fallopian tubes broken out for you, and that and the peritoneum are going to be the main focus of my presentation today. So you can see that those fallopian tubes connect that ovary to the uterus, and in pregnancy, obviously that egg travels through the fallopian tubes to implant in the uterus. So functionally, the ovaries are going to secrete estrogen and progesterone, which control the development of secondary sex characteristics, as well as regulating the menstrual cycle and pregnancy. And then, as I mentioned, the fallopian tubes conduct eggs produced and released by the ovaries to the uterus. And then you have that surrounded by the peritoneum, which is that layer of the abdomen composed of epithelial covering that protects those organs. And that would be the mesothelium and the underlying layer of thin connective tissue in between those organs. When we talk about peritoneum, we've got the visceral peritoneum that covers the visceral organs. We actually know this from coding lung cancer, and the parietal peritoneum as well. So that peritoneum is what allows organs, including the ovaries and the fallopian tubes, to move freely within that abdominal and pelvic cavity space. Mucinous ovarian carcinomas can also result in pseudomyxoma peritoni, and In that case, the peritoneum becomes filled with gelatinous material that causes abdominal distension and bowel compression. So this all leads to some of the ways that these patients are diagnosed. And we know that some types of ovarian cancer may actually start in the fallopian tubes and then spread to the ovaries. However, it's more common to have a cancer that starts in the ovary or the endometrium and spreads to the fallopian tubes. So more often than not, that's what we're looking for. But it can happen that those cancers can actually start in the fallopian tubes. And so we need to be careful when we are coding that primary site. And then, as I mentioned on the slide, that cancer can also begin in the peritoneum and then spread to the ovary. Evidence suggests that ovarian, fallopian tube, and primary peritoneal cancers all derive from those Mullerian ducts, and they are all usually managed the same way, which is why I'm talking about them together. The next slide, let's look at some regional lymph nodes for the ovaries. We've got our para-aortic lymph nodes, and those are indicated by number 1 up at the top of the diagram on this slide. We've got the common iliac lymph nodes. We've got the lateral sacral lymph nodes, the external iliac lymph nodes, the internal iliac lymph nodes, which are also called hypogastric, the obturator lymph nodes, those are number 6. So now we're really going to the interior of the pelvis. And then number 7 are our inguinal lymph nodes. And all of those, if you look at seer summary staging, should be considered regional. Now, this slide does not include pelvic or retroperitoneal lymph nodes, but I got excited when I found some of these anatomic images because sometimes it can be tricky for us to envision exactly where these cancers start. And it's also tricky for our physicians. Let's talk about some ovarian cancer statistics. And I had our epidemiologist, Dana Doyle, help me to pull some of these statistics for us so that we could really look at the impact of ovarian cancer in Arizona over the last 5 years or so, from 2018 to 2022, which is the last time that we pulled all of these statistics, because call for data, we're going to be looking at 2023 cases. So eventually you'll have new information if you go to our website. And you guys can actually find all of these reports on our ACR website. So if you haven't checked out our dashboard, it's really fascinating to be able to look by site and basically see a bird's eye overview of what cancers are more prevalent and even where they're most prevalent. Dana does a really good job keeping that up to date, and she gives us really helpful infographics if you're curious about what our top sites are and the overall impact of each of these cancers in the state of Arizona. So as you can see, ovarian cancer is the 19th most common cancer diagnosis in Arizona, not among our top 5 sites, but still a significant impact on our communities. And between 2018 and 2022, which is the last year we have full data and statistics published for, there was a 6.7% decrease in the rate of new invasive ovarian cancer cases in Arizona. And there was a 7.9% decrease in the rate of ovarian cancer deaths in Arizona. So getting less prevalent, but still pretty big impact. And as you see, only 23% of ovarian cancer cases were diagnosed early stage or localized. Those symptoms tend to show up later in the disease process, and it takes a longer time for patients to realize that they need to get evaluated, unfortunately. So you see that over 75% of cases are diagnosed at late stage, which is why it's so important to still do our surveillance efforts and to try and catch these patients earlier, because as we know, the earlier that these cases are diagnosed, the better the prognosis. So moving down my slide, the median age at diagnosis is 65 years old. And you can see a breakdown based on age. It's very, very uncommon in younger patients. You can see that from age 0 to age 19, only 1.4% of the total ovarian cancer diagnoses are made in that age group. So super rare the younger the patient is. And as we age, there's an increased likelihood of being diagnosed. But the median age or the middle age of diagnosis is going to be 65 years old. And you can see my breakdown here by age. So let's look at the counties. And again, this is 2018 through 2022. And these numbers on the county map reflect cases diagnosed per 100,000 women over that date range. So you can see the darker the county, the higher the percentage, the higher the number of cases diagnosed per 100,000 women. So Navajo, Mojave, and Cochise counties seem to have the most patients diagnosed in that category, and then it goes down from there. And then I also broke it down, Dana helped me break it down by age-adjusted rate, by race and ethnicity, and you can see that it's pretty widely spread by race category. And so there's just some overall statistics for you as we're talking about the impact of these cases. I was mentioning signs and symptoms, and so I thought it might be good to talk about some of these risk factors and the signs and symptoms. In earlier stages, there are typically no symptoms of ovarian cancer, which is why so many of these cases are diagnosed at later stage of disease. But some of those signs and symptoms include abdominal bloating, increased tightness of clothes with or without weight gain, unintended weight loss. And we always want to say unintended because that's what our physicians are looking for, are patients who lose weight without any known reason. So they're not trying to lose weight. Constipation, and that can indicate bowel involvement by these ovarian cancers, or any symptoms of extrinsic bowel obstruction, because that is what these cancers actually do, put pressure on those segments of the bowel. Nausea, edema or swelling, abdominal or pelvic pain, abdominal masses, and sometimes if the tumor deposits are impacting the bladder or the urinary system, you'll see urinary symptoms, including burning, urgency, frequency. You can have ascites as well, as fluid builds up in the abdomen. And that can often happen when the diaphragm is involved by tumor deposits, which affects normal fluid drainage from the abdominal cavity. And that ascites can present as a distended abdomen. So you may see references to that in the physical exam where they can actually tell that there's ascites and swelling in the abdomen. So some of our risk factors I have on the slide: age and postmenopausal status in particular. Race can be a risk factor. Any prior history of breast or endometrial cancer can make someone more likely to develop an ovarian cancer. Family history and a first or second degree relative. There are some mutations that they look at. So BRCA mutations, they might be able to identify patients who are at higher risk if they're doing genetic testing for BRCA mutations. And I would imagine that ties into that history of breast cancer as well, because those patients may end up having some of that genetic testing. You may see Lynch syndrome as a risk factor for ovarian cancer, endometriosis or a history, nulliparity, which means no children or infertility, and obesity. So most of these are not factors that patients themselves can modify based on lifestyle or behavior. A lot of it is genetic or age-related. So let's do a little pop quiz, and I'm going to actually try to pull up the pop quiz so that you guys have a minute or two to answer. So give me 1 second. And I will see if I can launch that. But you can be thinking about that answer because I do have the question up there. And we will see how we do. So the question is, the ovaries secrete the following hormones. And I want you to think of all of those hormones that may apply. So take a moment. And let's just have you go ahead and put your answers in the chat for this one. And I'll give you a minute or so. Oh, I'm seeing some good answers. Give it another 30 seconds if someone else wants to weigh in. All right, it seems like the majority are going for 1 and 4, which is estrogen and progesterone, and that is correct. So well done on that. Those are the two primary hormones that are secreted, and especially postmenopausal, they might see a significant variant in estrogen and progesterone levels than they might expect for someone who's postmenopausal, and that may be one of the factors that leads to a diagnosis. So good job paying attention on those. Let's talk about solid tumor rules. And all three of these malignancies that we're talking about today are going to be using the solid tumor rules other sites module. So those are for cases diagnosed 1/1/2023 or later. And hopefully that's all the cases that we're abstracting now. We should be in 2023. If you see a case that's diagnosed prior to January 1st of 2023, you'll want to go back and look at the 2007 multiple primary histology rules. So those new solid tumor rules for other sites were updated in 2023. Let's look at the common topography codes. We've got ovary, which is C56.9. We've got peritoneum, and again, we're talking female peritoneum is what we're going to be covering today. And the peritoneal cavity, and that's going to be C48.1, C48.2, and then our overlapping code C48.8. We've got the fallopian tubes, also maybe called the uterine tubes, and that's going to be C57.0. You might have cases coded to other specified parts of the female genital organs, and that would be your C57.7 if it falls outside of those codes. Or you may have an overlapping lesion of female genital organs, might be referred to as tubo-ovarian or utero-ovarian, and then you can use your overlapping C57.8 site code, or you could use the NOS code. Hopefully your physicians are going to give you some good guidance to determine exactly where that primary originated, because that's what we're looking for. And you should hopefully be able to assign it to ovary, fallopian tubes, or peritoneum. But especially if your facility didn't diagnose that patient and you don't have a lot of the workup information, you may have to use some of these NOS codes or overlapping codes, and they are there to be used appropriately. So what do our pathologists consider when they're determining the primary site for these cases? Because as I mentioned, it can be tricky. Is there serous tubal intraepithelial carcinoma or STIC present? Well, then they're going to be leaning towards fallopian tube origin. Or is there invasive mucosal carcinoma in a fallopian tube with or without STIC? That would also lead them to lean towards the fallopian tube. If that fallopian tube is partially or entirely incorporated into a tubal or tubo-ovarian mass, they may lean towards the fallopian tubes. If there's no STIC or invasive mucosal carcinoma in either tube in the presence of an ovarian mass, then they're going to be leaning towards the ovaries. If both the tubes and both of the ovaries grossly and microscopically are normal in the presence of peritoneal high-grade serous carcinoma, then they might lean towards the peritoneum. And I've also given you a page number to go in the SEER manual for 2025, because SEER does a really good job at breaking down these primary sites. And SEER also is behind the solid tumor rules, so it's very consistent. For primary peritoneal cases, ovaries are not going to be involved, as I mentioned, or there may be surface implants only. And those peritoneal patients, again, typically present with later stage of disease. We are not supposed to be considering peritoneal metastases when we're assigning primary site. Remember that metastatic disease means that those solid tumor rules are not going to apply in those cases because we're looking for the actual site of origin. So we want to know if that started in those cases with the ovaries or the fallopian tubes. And that instruction that I have listed on page 111 says, when the choice is between ovary, fallopian tube, or primary peritoneal carcinoma without designation of the site of origin, any indication of fallopian tube involvement indicates the primary tumor is a tubal primary. Fallopian tube primary carcinomas can be confirmed by reviewing the fallopian tube sections as described on the pathology report to document the presence of either serous tubal intraepithelial carcinoma, or STIC, and or tubal mucosal invasive serous carcinoma. So we want to be looking at the whole op report. We also want to be we may need to look at the gross section of the pathology report. So if you are just looking at the synoptic portion of the pathology report, you may be missing information that might lead you to coding the primary site differently. So make sure that you're going through the entire pathology report, especially with these cases, to determine what is involved and what isn't, and where that primary site might be. In the absence of fallopian tube involvement, and this is going back to SEER page 111, refer to the histology and look at the treatment plans for the patients. If all else fails, assign that C57.9 as a last resort. So we shouldn't be jumping there, but you may have cases where that C57.9 does apply. So hopefully that'll help us when we're looking at these cases. So for primaries that start in the ovary, here are some of the common histologies. Most of those ovarian cancers are going to be epithelial or glandular, and that's going to include all of our various forms of adenocarcinoma, our serous carcinomas, and undifferentiated or dedifferentiated carcinoma. And just to define epithelium for you, I've got that definition right there. This isn't a complete list, so you're going to want to look at table 13 in the solid tumor rules and the ICD-0 3.2 tables for further synonyms and subtypes for all of these. These ovarian tumors are really categorized by cell type, as you can see in my breakdown. So that epithelium is what covers the outer surface of the ovaries, and they are glandular cells, which is why so many of these present as some of these glandular type of tumors. So here are some of the common non-epithelial ovarian histologies that you may run into. You may see germ cell carcinomas or immature teratomas, dysgerminoma, yolk sac tumors, embryonal carcinomas, or mixed germ cell tumors, or choriocarcinomas that present as ovarian primaries as well. And for ovarian primaries, code 9084/3, which is teratoma with malignant transformation, gets coded when a malignant histology arises in a benign teratoma. So don't forget the general ICD-03 instructions about how to code behavior for these tumors. Let's look at some common fallopian tube histologies. You're going to see that in table 15. If you look at the solid tumor rules, you've got adenosarcoma or mesodermal adenosarcoma. You've got carcinosarcomas, adenocarcinomas again. You can have serous carcinomas, and in fact, that STIC is an indicator that that primary may have originated in the fallopian tubes. And you may see teratomas as well. So you want to carefully review that fallopian tube section of the pathology report to confirm the presence of serous tubal intraepithelial carcinoma and or tubal mucosal invasive serous carcinoma. And you can see right in the names, tubal, we're talking about those fallopian tubes. So those are the primaries that tend to get coded to fallopian tube. And hopefully, like I said, our physicians will be really clear about the origin, but they might not. So let's take a little bit closer look at STIC. For 2018 cases forward, serous carcinoma can be broken into low grade and high grade. They get coded to 8144 regardless. And I'm not going to cover AJCC staging other than to say that TIS is not a valid value for AJCC if we're looking at fallopian tube, but they're going to be in situ for SEER summary stage. So there is a slight difference there. You're going to want to look at the staging manual for what you're staging and go by their rules. And again, STIC can be associated with a BRCA mutation, so they may be looking at that. And starting with 2024 plus cases, ovary as primary site and serous carcinoma is going to trigger an unlikely edit based on cancer path chart and their algorithm. It can be overridden as necessary if you really find evidence in that case that ovary should be the primary site. There are flags that you can code, but you are going to get an unlikely edit if you try to code STIC or serous carcinoma to ovary as primary site. So I wanted to highlight that for you a little bit as well. Another rule that I wanted to point out was M9 when we're looking at multiple primaries. Bilateral epithelial tumors, and they give you the range of histology codes of the ovary within 60 days are a single primary. I see people submit cases and they're not looking at the dates when these were diagnosed. So if it's bilateral and it was diagnosed within 60 days, single primary. And we have a couple of notes that I've got on that slide for you. Tumors must be the same histology or be an NOS and subtype variant. And they give you a definition of what the same row means. So we're going to have to get comfortable with looking at those charts with what the solid tumor rules mean when they're calling something a subtype or a variant. And a hint is subtypes or variants have their own unique histology code that is different from the histology code in the NOS column. So that's what they're talking about. For ovary, it's going to be table 13. For fallopian tubes, I believe it's table 15. But be comfortable using those charts. Be comfortable with what each of the columns means so that you can use the solid tumor rules as they are intended. And obviously, we're going to go through them in order, but M9 specifically relates to ovarian primaries. So I did want to take a moment and point that out for you. Let's talk about combination codes. We have two rules that cover combination codes that apply to these GYN sites. If it's an in situ case, it's going to be H7. If it's an invasive case, it's going to use H21. It's basically the same rule, and you use the rule that applies to your situation. And it says code a combination code when there are multiple specific in situ histologies, that's referring to H7, or when there is an NOS with multiple specific in situ histologies, and then just replace in situ with invasive if you're using H21. And notice that and the combination needs to be listed in table 2 in the equivalent terms and definitions section, ICDO and all updates, or you receive a combination code from an Ask a SEER registrar. And I know I've had to ask about a couple of these to see what combination code or what code they want me to use in these cases. So table 2, these are the sections of table 2 that I thought were applicable to these GYN malignancies. So I pulled that out for you. And you can see on my slide what those required terms are and what the combination code is. This is not meant to be exhaustive. You can go to table 2 for yourself. It's in the Solid Tumor Rules Manual, and you can apply the appropriate rule for these cases. In fact, I've got a pop quiz coming up, so you may actually want to pull out your solid tumor rules so that you can follow along and code correctly. So get out your solid tumor rules manual if you've got access to it easily, and be ready to code a histology because we've got a question coming up for that. So here is pop quiz number 2, and I'm going to ask you to put your answers in the chat again, and I will give you a few minutes to answer that, and we'll see what we get. So this question, here's our case. This is a pathology report from a total abdominal hysterectomy and a bilateral salpingo oophorectomy. TAHBSO are the acronyms for that. And here's the final pathology. We have a high-grade serous carcinoma, 95% of that tumor, and clear cell adenocarcinoma, 5% of bilateral ovaries. There was a right ovary capsule rupture and a left ovary capsule rupture. And the right ovarian tumor was 11 centimeters. The left ovarian tumor was 10.5 centimeters, which no wonder that capsule ruptured. Those are 2 large tumors in this case. So how should that histology be coded, and which histology rule applies? I'll give you a couple of minutes to think it over, and we'll see what we get in the chat. I'll give you another couple of minutes to work through this scenario, especially since we've got a little extra time here. Another 30 seconds or so in case anyone wants to add an answer. Be bold. All right, well done. That is the correct answer. This is going to get coded to 8323/3 per H21. And someone actually gave the M rule as well, which is impressive. So good job on that one. It's a little tricky when we have these combination codes. In general, for these ovarian primaries, we're going to code subtype variants, and 8323/3 is one of those subtype variants listed in column 3. The greater percentage doesn't apply here. So we need to be reading through our solid tumor rules, because sometimes we code to whatever the greatest percentage of tumor is, but the other sites module does not instruct us to do that. So take a moment when you're starting to code for a site that you haven't done in a while or that you're not sure about, and read through that terms and definitions section of the module that you're working with to make sure that you are coding correctly. We would ignore that greater percentage, and we are going to code the combination code in this case. So good job with that one. Let's talk about summary staging. And there are two distinctive summary staging schemas that apply. The first one I'm going to look at is the schema for ovary and primary peritoneal carcinoma. And you'll see that they actually do include female only. So you're not going to use this if you're trying to stage a primary peritoneal carcinoma in a male. And these are the primary site codes that apply. So you'll see this is one of the reasons it's important to distinguish between ovary and fallopian tube as our site of origin, because when you're summary staging, fallopian tube has its own unique schema that's going to get used. So this is talking about ovary. Here are some general notes. And note 2, if you didn't catch it based on the description of the schema and the primary sites included, tells you use the retroperitoneum schema if sex is coded 1, 3, 5, or 9. And I'm assuming that there are going to be some updates, although I haven't seen the new updates to the solid tumor manual yet, but I believe this is probably going to be updated to incorporate that new data item that Michelle was talking about earlier. And so you want to read those notes to make sure that you're using this schema correctly. Note 3 says that ascites should be excluded as a staging element, so we don't take that into account for these cases. Note 4 tells us to see the definition of ITCs, or isolated tumor cells, in the summary stage manual, because there are some differences in how isolated tumor cells are applied when it comes to AJCC stage versus summary stage. So read the notes, use the correct manual for the site that you are coding. And note 4 also says that isolated tumor cells only are not counted as positive nodes for the purpose of summary staging. So we need to know that. That's important. Note 5, we need to get microscopic confirmation of peritoneal implants outside of the pelvis. So we need to be careful because that peritoneum also covers the abdomen. So we need to know whether those implants are in the abdomen or the pelvis to be able to stage correctly. And those implants may also be called seeding, salting, talcum powder appearance. I've never seen that one on an op report or a path report, but anything's possible. Studying is another term that they use. And we really have to determine whether those implants are in the pelvis or the abdomen, because that makes the difference between regional or distant when it comes to summary stage. And we're told if they don't state it and we can't figure it out, code to distant. Assume that they are abdominal peritoneal implants. It's tricky. So I'll start with in situ and go from there. In situ tumors are limited to the ovarian mucosa. They might be called pre-invasive, and serous tubal intraepithelial carcinoma is included as well. This is a separate decision, assigning the stage versus assigning the primary site. And I'm going to show you what the fallopian tube chapter looks like as well. Localized only. Capsule has to be intact. Has to be limited to one or both ovaries with or without surgical spill. Limited to one or both ovaries without or unknown tumor on ovarian surface or malignant cells in ascites or peritoneal washings. Confined to the ovary, NOS. Localized NOS. And now we start to get into FIGO staging, because that FIGO stage is going to be tied in to summary stage. And I'm really excited, you'll see in a second, because I have some slides for FIGO stage. I found some really good illustrations to share with you guys. So let's look at that. If we're looking at localized, it's FIGO stage 1, including 1A, 1B, 1C1, or 1 NOS. So what is FIGO stage 1? Well, it is confined to the ovary. Stage 1A means that there's cancer in a single ovary. Stage 1B means cancer in both ovaries. If you have involvement of the surface of one ovary, code that FIGO stage for that would be 1C. 1C1 is if there's surgical spill. And again, you're going to want to look at the op report and the path report just to confirm. 1C2 means that the capsule has ruptured or there is tumor on the ovarian surface. And 1C3 is positive ascites or washing. So most of those are going to be covered under localized, but just 1A, 1B, 1C1, or 1 NOS. So we're still going to see some of the higher stage 1 subcategories when we're looking at our regional stage. But I wanted to give you guys an idea of what our physicians are talking about and what they're looking at when they're coding FIGO stage. So let's look at regional by direct extension for these ovarian cases. Limited to one or both ovaries with tumor on ovarian surface. So now that tumor has started to spread outside of being limited to the ovaries. Or you have malignant cells present in ascites or peritoneal washings, or you have pelvic extension NOS below the pelvic brim. Or you can have extension to, and it's interesting because usually we think of regional by direct extension as literally being direct extension, but serous summary stage actually does look at some discontinuous metastases because these ovarian primaries spread that way. They have that peritoneal seeding. So even if you have discontinuous metastases, if that seeding is confined to the pelvis, it's still going to fall under regional by direct extension. So you've got extension to and or discontinuous metastases to the adnexa, to the adjacent pelvic peritoneum, to the bladder, to the corpus uteri, to the cul-de-sac, or they might call it the rectouterine pouch, or to the fallopian tubes, or to any of the uterine ligaments. And when we reviewed anatomy, that's part of the reason why, because we know how close those female reproductive organs are both to the bladder and to the digestive system, to the colon, certain segments of the colon. So if you have extension or discontinuous mets to any of these sites within the true pelvis, you can code that as regional. And then we have FIGO stage 1C2, 1C3, or FIGO stage 2, 2A, 2B, or 2NOS. So here's FIGO stage 1C, and you can see that those are the cancers that have spread outside of being confined within the ovary. So it makes a lot of sense that that would fall under regional, or positive ascites or washings. So what is FIGO stage 2? Stage 2A, you can see that that has exited the ovary, and this one seems to be directly extending into the infundibulum of the fallopian tubes. You've got stage 2B, which has spread to the bowel or the bladder, because they are both very close to these ovaries. Or stage 2C, cancer cells can be found in the fluid of the abdomen. So you can see why those would fall under our regional category. Let's look at some regional lymph nodes. And I already gave you a slide earlier in the presentation when I was talking about the anatomy, and those are our regional lymph nodes. You're going to want to familiarize yourself with that list. I can never memorize them all. That's why we have our manuals, so that we can look and see what regional is. So these are our regional lymph nodes, and you can see that those are mostly pelvic lymph nodes. All the different groups and other terms. So if it's a term that you aren't familiar with, you want to go through the list of regional lymph nodes carefully, because Sarah does a really good job at explaining exactly what other terms are used. So, oh, look, now we're getting into FIGO stage 3, which is spread to the lymph nodes, and all these subgroups of FIGO stage. So we've also got FIGO stage 3. Here's my little illustration for FIGO stage 3, 3A, 3B, 3C. So FIGO stage 3A means that cancer cells are in the lining of the abdomen, the peritoneal lining. We usually only can see that under a microscope, so you're going to look for that with the path report. But 3A1 means that there are metastases in these retroperitoneal lymph nodes, which is why it's categorized under regional by lymph node extension. And it's even broken up into 3A1 and 3A1-2, depending on the size of that metastatic deposit. So hopefully in our pathology report, we are going to have a good description of the size of that metastatic deposit, because that will help us to determine the subcategory for all of these. 3A2 is going to be microscopic metastases in the peritoneum. Microscopic can only be seen under the microscope. These are not gross metastatic deposits, regardless of the retroperitoneal lymph node status. And usually they consider microscopic to be smaller than 2 centimeters, has to be seen under a microscope. So that's going to be your FIGO stage 3 categories. Now let's look at distant. Distant sites include contiguous extension to the abdominal mesentery. So now it's left the true pelvis, and we have seating or implants, or however they're describing it, in the abdominal cavity. The diaphragm's located in the abdomen. That makes sense. Gallbladder, intestine, large intestine, other than what's specified under regional. So we would have to go back and look at regional to see what colonic subsites are included under regional. And I'll go back real quick to show you that. So they mention the rectosigmoid, the rectum, and the sigmoid colon as being regional when it comes to ovary. And so it's important that we figure out, if we can, what segments of the colon are involved, because it may be regional, it may be distant, depending on exactly what is involved. Extension to the kidney or the liver or the omentum or the pancreas. Peritoneum NOS, we assume distant if we don't know for sure that it's confined within the pelvic, or peritoneal implants beyond the pelvis. Pleural effusion, obviously that's distant Mets to the lung, well, to the pleura rather. Mets to the small intestines, those are all considered distant. Mets to the spleen, Mets to the stomach, Mets to the ureters, because the ureters are outside of the pelvis, or at least a portion of them are. Any distant lymph nodes that may be included, carcinomatosis, or any of these higher level FIGO stages. So FIGO stage 4, I've shown you 1 through 3. Here's FIGO stage 4. Spread to other organs, spread outside of the pelvis. And again, these can be direct extension or discontinuous Mets. We don't always think about the fact that direct extension can extend more than regionally. That tumor can grow so large that it's gone all the way through the regional tissue and extended directly to distant tissue. It happens. So we want to make sure that we correctly capture that summary stage. Let's look at fallopian tubes. I'm not going to spend an extensive amount of time talking about fallopian tubes because it's very similar to ovary, but I will point a few things out. And we've got our same notes talking about extension outside of the pelvis and making sure that it's microscopically confirmed. Those same terms apply to peritoneal implants. It's looking very similar, and it is very similar. And again, you have that serous tubal intraepithelial carcinoma, or STIC, is going to be in our in situ category. Localized, you've really got the same FIGO stages. The only difference is confined to fallopian tube instead of ovary. Makes sense, we're talking about fallopian tube primaries. Limited to 1 or both fallopian tubes without or unknown if there is malignant cells in the ascites or the peritoneal washings. If we have malignant cells in ascites that have been microscopically proven to be there, then that's going to be more than just localized. Regional by direct extension. Again, this is going to be outside of the fallopian tubes or extension to any of these sites. And if you look at the summary stage manual, they're basically the same sites that fall under regional for ovary or primary peritoneal carcinomas, except replace fallopian tubes with ovaries because this primary started in the fallopian tube. So the ovaries are now going to be a regional site. And again, discontinuous Mets count to any of these sites as regional as well. Same grouping of FIGO stages, which now we have a good map of what they mean when they talk about FIGO stages. Distant Mets, same basic category, same basic sites listed. Any of the sites within the large intestine, unless it's rectal, rectosigmoid, or sigmoid, are going to be captured as distant. So let's do another pop quiz, and you may want to get your summary stage manuals open so that you can follow along. And let's see what we're looking at for this case. Again, you can throw your answers right in the chat, and I will look to see when we have a good grouping of answers. So let's assume this is a case diagnosed in 2025. The pathology is a biopsy of the abdominal wall, metastatic high-grade serous carcinoma consistent with ovarian primary. Well, at least they're giving us the primary site, so that helps. Imaging was taken. There are multiple bulky omental peritoneal masses measuring up to 8.3 centimeters in the right abdomen and the right upper quadrant of the peritoneum. The largest deposit measures 4.5 centimeters. Findings represent metastatic disease. There are additional areas of serosal involvement without bowel obstruction. They did a CT chest without contrast, and we have evidence of pleural metastases. Mild abdominal ascites, likely malignant. and there are findings of peritoneal carcinomatosis. So what is the correct summary stage for this patient? And if you want to throw the primary site in there, that is totally fine too, because then we'll know exactly which schema we should be using. All right, I will give you a couple of moments for that, and I'll check the chat. And I do see a note in the chat to make sure you're reading the rules about whether or not we can code the FIGO stage before you do. That's exactly correct. I just wanted to give you an idea of what our providers are looking at when they're coding FIGO stage, because it is referred to in summary stage. So even if we don't know what the FIGO stage is, we can still code the summary stage. But yes, we do want to be careful. They should be giving us the FIGO stage. So good point about that. Give everyone about another minute to do this. I do see a few answers showing up. All right, about another 30 seconds. And then I'll go ahead and answer. And the answer is distant. We have disease spread far beyond the true pelvis. Not only do we have confirmed abdominal metastases with that abdominal wall biopsy and some of the sites that fall outside of the true pelvis, but we even have thoracic involvement. We've got pleural metastases. So definitely distant for summary stage. Good job with that one. Let's talk about treatment. I'm primarily going to be covering surgery, but there are a few other treatment modalities that I want to talk about as well as we go through this section. So here are our ovary surgery codes, and these come straight out of STOR Appendix A. We moved to the new surgery codes back in 2023 as well. So those have been updated in our 2025 STOR manual, and you should see Appendix A, including all of these 3-digit codes with the A or the B in front of them. This is going to be, all of our ovary surgery codes are going to be A followed by a 3-digit code. I think the only sites that use the B at the moment are melanoma, and I think there may be a couple of others, but melanoma is the only one that comes to mind. So our options are no surgery would be A000. A170 is going to be local tumor destruction. So in those cases, no specimen gets sent to pathology. And we know that we're not going to need to look for a pathology report because they didn't take any specimens to go to pathology. I haven't seen very many cases where A170 would apply. Usually they try to do a total removal of the ovary. So our A250 covers the removal of a single ovary. A260 is going to be a little more specific. Wedge resection or subtotal or partial, and we don't know if there was a hysterectomy done. So we want to be looking to see if there was a hysterectomy done, a TAH, a total abdominal hysterectomy so that we can code the more specific over the NOS code. So A250 is our NOS code, and we want to code the more specific surgical codes when we appropriately can. So if we know that there wasn't a hysterectomy done, then we should be coding that to A270. And if there was a hysterectomy performed at the same time, A280 is going to be the correct surgical code. So moving up, and again, we know that as these surgery codes increase in number, the higher the number, the more extensive the surgical procedure. So A300 is a unilateral salpingo-oophorectomy, unknown if there was a hysterectomy done at the same time or in the same procedure. So what's the difference? Well, in the A250 category or the subcategories, just the ovary was removed. A salpingo-oophorectomy means that they are also taking that fallopian tube as well as the ovary. And mostly I've seen either a unilateral or bilateral salpingo-oophorectomy. So I don't code the 250 and subcodes very often. Usually it's at least a 300 level surgical code. And again, they want to know based on the surgery code if that total abdominal hysterectomy was performed. A360 means that we know it wasn't. A370 means we know it was. And that should be pretty clear from the op report and the path report. So to give you an idea, and we know that, what gets removed in a total abdominal hysterectomy or a TAH? Well, the uterus and the cervix get removed. So going back to our anatomy, you can see that, I guess it's a teal color circle that shows you what gets removed. And you can actually look at our NCI dictionary of cancer terms that defines it for you there as well. But in a total abdominal hysterectomy, the uterus is removed and the cervix is also removed. But you'll notice what is not removed in a TAH, and that is all of these other fallopian tubes, ovaries, etc. Here's a salpingo-oophorectomy. That removes the ovaries and the fallopian tubes. Going back to our terminology, a USO means that it was a unilateral, one side, that's what that means, salpingo-oophorectomy, and BSO is a bilateral salpingo-oophorectomy. So if you have a TAH BSO, that means that they did a total hysterectomy as well as a bilateral salpingo-oophorectomy. Now, what's the difference between that and a radical hysterectomy? Well, in a radical hysterectomy, they're going to remove the uterus, the cervix, which is not done if they're doing a total hysterectomy, the ovaries, the fallopian tubes, part of the vagina, and any surrounding ligaments and tissues. So it is a much more extensive surgery, which requires a much more extensive code. So then the next option we have is the A500, which is a bilateral salpingo-oophorectomy. And remember, this is for ovary. So if they're taking both ovaries and fallopian tubes, it's going to fall in the 500 level of surgical codes. A510 is going to be without a hysterectomy. A520 is going to be with a hysterectomy. So we really need all that information to be able to code that. Now, if they remove part of the omentum, which oftentimes they will, especially if there's intraperitoneal spread or omental spread, then that's going to jump it up to the codes that are covered in the A550 range, including A560 or A570. And again, that's going to include or not include a hysterectomy. So to code that, you have to know whether they did a hysterectomy. A600 is a debulking. It's also called cytoreductive surgery. And A610 includes portion of the colon or small intestine resection. And that's done purposefully because they suspect cancer has spread there, if it's not incidental. A620 means that they also remove part of the urinary tract, especially if they think that urinary sites or bladder, which is a urinary site, are involved. Or it could be an A630, which means that they did a debulking and also removed those sites that are covered by A610 and A620. So debulking is going to be partial or total removal of a tumor mass, and it can involve the removal of multiple organ sites. It may also include the removal of the ovaries and or the uterus. The pathology report may or may not identify ovarian tissue. Usually they're going to follow debulking with another modality such as chemotherapy. Lots of times it is chemotherapy, and I'm going to talk about chemotherapy later. But for what we need to know to code these surgical codes, there you have it. And they're going to talk about, hopefully in the op report, how thorough that debulking was, how much residual tumor is left. So if you see R0, that is going to mean that it was a complete cytoreduction. There's no macroscopic evidence of tumor when they're done with it. And then you can see what an R1 or R2 means. But that's our provider's way of telling us how much they actually removed when they did a debulking, because sometimes they can't get it all. Sometimes those tumor deposits involve vital tissues and organs, and they just do the best they can. And they follow it up with chemotherapy or another modality to remove the rest. So as we move up, what's more extensive than a debulking? These terms always seem so major to me, and I guess they are, because look what gets removed under an A700. It's a pelvic accentuation, and that can be done anteriorly or posteriorly, in front of or behind the pelvis, or it can be total accentuation. And you can see on this slide what gets included. So if it's anterior, they'll be taking the bladder, the distal ureters, and the genital organs with the ligaments and attachments and some pelvic lymph nodes. They're doing such an extended surgery, you're probably going to see some pelvic lymph nodes there. If they're doing a posterior accentuation, then that's going to include rectum, rectosigmoid colon, with the ligaments and attachments and pelvic lymph nodes. If they take everything, code to 730. So again, don't use those on OS codes if you can code to more specific surgical codes. And they could even do an extended accentuation, which would include pelvic blood vessels or portions of the bony pelvis. And then you have A800, salpingo oophorectomy NOS. You should know, if you have the op report and the path report, I can't imagine a scenario, although I'm sure there's an example to prove me wrong somewhere, where you wouldn't know whether it was unilateral or bilateral. So there is that code available, but I usually find plenty to be able to assign the appropriate surgery code. And then, of course, you also have your A900, which means there was surgery done, but I have no idea of what other surgery was performed. Usually, I would imagine that would apply more to non-analytics, because if you did the diagnosis or part of the first course of treatment, you should hopefully have enough records to know what the specific surgery was, especially if you have access to some of your clinician's notes to tell you what surgery the patient has, because they're going to want to document that. And then there's the A990 code, which means it was unknown if surgery was performed as part of the first course of treatment. So a 900 means I know they had surgery, I have confirmation of that, but I have no idea what the surgery was. Whereas an A990 means I don't know if they did surgery, period. They should have, but I don't know if they did. So let's look at our second range of surgical codes. This is going to cover primaries in the fallopian tubes or the peritoneum. So again, you see why it's so important to do our due diligence and code primary site correctly, because you're going to be using the wrong surgery codes if you're coding to the wrong primary site. So if it is a fallopian tube primary or a peritoneal primary, those all other site surgical codes apply. Again, you have A000, which means that there was no surgery of the primary site. That's part of the first course of treatment. A100 means that there's local tumor destruction and we don't get specimens sent to pathology. Here under the A100 codes, we have more specific codes that allow us to indicate what the method that was used to destroy tumor cells was. So we've got our more specific photodynamic therapy, electrocautery, where they use electrical currents to seal off that surgical site. Cryosurgery means that they freeze the tissue to destroy those tumor cells. And we have a laser surgery code, which is A140. And that applies in our all other sites. If we're talking ovary, you've got to go back and look at the surgical codes for ovary. Then we have local tumor excision, polypectomy, and excisional biopsy. You're not really going to use A260 for fallopian tubes or peritoneum. That's more for other alternate sites that get coded under those codes. But you will sometimes see excisional biopsies. Usually they really do try to do a salpingo-oophorectomy or a total abdominal hysterectomy. We do have a combination code for the 200 level surgical codes, which includes the same type of tools, but this time it's being used to remove tissue, not just destroy it, and you will have a pathology report. Simple or partial surgical removal of the primary site. If you have a total surgical removal of the primary site, that gets coded to a 400, not a 300. Or you might have a debulking surgery, especially for those primaries that start in the peritoneal space. Or you could have 600, which is radical surgery. We know it's more than just stated to be debulking. And radical surgery is defined in my little green box that I have on this slide. It includes partial or total removal of the primary site with a resection in continuity with other organs that are not specified by that total removal of the primary site. So makes sense, two different groups of surgical codes depending on what primary site you assign it to. Here are the principles of surgical resection, and I got these straight out of the NCCN guidelines because I like to know what my physicians are thinking and what the standard of care is. In the synoptic op report, we can look for the extent of initial disease before the debulking. These cases are where I usually have a very lengthy text surgery because I want to record any of the sites that the surgeons saw that were involved by tumor, because that's going to impact my staging. Oh, I have the R codes for you. We don't code that information, but it's good to know how effective that debulking was. So how do our physicians look at surgical resection when it comes to these cases? An open laparotomy should be used in most patients with a suspected malignant neoplasm of ovary, fallopian tube, or peritoneum when a surgical staging procedure, primary debulking procedure, interval debulking procedure, or secondary cytoreduction is planned. Laparotomies tend to heal a little bit better than completely open debulking surgeries, so it's better recovery for the patient. And they're going to want to do laparoscopic surgery when it is indicated and use those minimally invasive techniques. If the patient is unable to be debulked using a minimally invasive technique like laparoscopy, then it should be converted to an open procedure because they want to debulk as much as possible and get them as close as they can to an R0 debulking. And even for advanced stage patients, they may still do a laparoscopic procedure. They're not removing everything, it's not surgical, but they may still do a laparoscopy to evaluate whether optimal cytoreduction can be achieved. And they're going to try to perform an omentectomy where they can. So if they're doing a complete debulking or resection, then they should indicate that. And if it's incomplete, they should still indicate the size of any major lesions and the total number of lesions, even miliary or small lesions that are left behind. If they're calling it an R0 resection, that means complete remission or cured. Typically, it's going to be either R1, which means there's only microscopic residual tumor, or R2, where you can see with the naked eye that they left some tumor deposits there. So that's what they mean when they use those abbreviations. Let's talk a little about radiation. I'm just going to talk about that quickly. Whole abdominal radiation is rarely used for epithelial, ovarian, primary peritoneal, and fallopian tube cancers. I can't remember seeing it. I'm sure there's a case somewhere out there where they do radiate that patient. You're going to want to follow the radiation instructions in STORE to code the case in the radiation data items in section 2 and also appendix R to have the most accurate treatment codes that you can. So they may use localized radiation after a recurrence and do it in the palliative setting. They should be telling you that it's done for palliation rather than curative. And of course, if radiation was not included as first course of treatment, that's going to be subsequent treatment. Why don't they do radiation for these primaries? Well, these patients may be more prone to vaginal stenosis and impaired sexual function. So they're looking at the potential impact on the patient versus the good that they can achieve with radiation. So I'm not going to spend a whole lot of time on radiation, just give you a little discussion of that. Okay, systemic therapy. And again, I went through the NCC and guidelines to see what standard of care looks like. When would they do neoadjuvant systemic therapy? Well, that patient may be a poor surgical candidate, so they're not planning on doing a resection, so they need to see if that patient can be made a surgical candidate. Or they go in, they might do a laparoscopy and determine that they're not going to be likely to get optimal cytoreduction. So they do neoadjuvant therapy to see if after that they're able to. Because remember, if they can remove that cancer, they're going to try to remove it surgically. If they can't, then they're going to throw whatever systemic therapy they can at it to kill as many tumor cells as possible that way. If it's non-invasive, they may do neoadjuvant therapy in those cases. When would they do adjuvant therapy after surgery? Well, if they can't fully cytoreduce that patient, they're probably going to want to do some sort of systemic therapy, or if they have microscopic residual disease after they do cytoreduction or surgery. Typically, you're going to see platinum-based therapies like carboplatin or cisplatin. Platin is right in the name, and that helps us see that that is a platinum-based therapy. As long as that cancer is platinum sensitive, that's the route that they're going to prefer to go. And again, I come back to BRCA status because they may choose a treatment modality dependent on that BRCA status coming back. They might consider hormones. Some of these cancers are hormone sensitive, so they might add in hormone. I don't see it very often, but stranger things have happened. And there are immunotherapy treatments that they can give. Usually, if a drug is listed with MAB at the end of it, that's going to indicate immunotherapy. We're going to want to look all of these up in SEER-RX to make sure that we're coding it as chemotherapy, niraparib, rucaparib, or olaparib are the typical chemotherapy agents given in an adjuvant setting. And bevacizumab is the immunotherapy that they may tend to give adjuvantly. So let's talk a little about those common adjuvant therapies. Those 3 chemotherapy drugs listed are drugs that block enzymes called PARP. And that helps, those enzymes that they're blocking help repair damaged DNA in cells, including cancer cells. So if they block those enzymes, that tumor is going to be less likely to be able to repair itself. So that's why they give those particular drugs, because they are known to block those PARP enzymes. Olaparib is FDA approved as maintenance treatment for patients with a germline or somatic BRCA mutated advanced epithelial, ovarian, fallopian tube, or peritoneal cancer who are in complete or partial response to first-line platinum-based chemo regimens. So they will add in olaparib for those patients where they weren't able to give them a complete response to platinum-based chemo regimens, or they did get a complete response, but they want to prevent the likelihood of recurrence, or they give that particular olaparib chemotherapy drug because of those somatic BRCA mutations or germline mutations. Rucaparib is approved for patients with advanced ovarian cancer who have been treated with 2 or more chemotherapy drugs and who have a deleterious or unfortunate BRCA mutation. So you may see that for that reason. It could be subsequent treatment. Look at the treatment plan. Make sure that you know what their first-line treatment was supposed to be. Niraparib is approved for patients with recurrent ovarian fallopian tube or primary peritoneal cancers as a maintenance treatment. And they don't have to do biomarkers for niraparib. So that may be why they're prescribing that chemotherapy drug. Almost done, and I want to make sure I leave us time for questions that have come in. I wanted to talk about HIPEC. I'm not sure how many of you see that in your notes, but HIPEC is also called CHPP, or continuous hyperthermic peritoneal perfusion. Hyperthermic, temperature related, thermic relates to temperature, hyper means above, basically. So they're increasing that temperature. And you can see an image that I've got on the right-hand side of this slide where they are actually heating up those chemotherapy drugs and then infusing them into the patient. It's infused directly into the abdominal cavity. It's typically given during surgery. And they may consider HIPEC along with cisplatin for stage 3 or more advanced disease. Stage 4, it would be if that's a patient who's responded favorably to neoadjuvant treatment, or patients whose disease sites have completely resolved if they're stage 4, or patients who have become resectable. They may still decide to do HIPEC just as insurance. And they do have some concerns about the impact of HIPEC on the kidneys, so you may not see it if a patient already has kidney disease or impaired kidney function at the time of the diagnosis for their cancers. Why do they give HIPEC? Well, heat can increase the penetration of chemotherapy and enhance the sensitivity of cancer cells to chemotherapy. So they want to heat up that chemotherapy medication because it allows that chemotherapy drug to perfuse the tissue more effectively and make those cancer cells a little bit more sensitive or reactive to chemotherapy. So it gets better response if they heat up those chemotherapy drugs. Heating the chemotherapy drugs also inhibit DNA repair of those tumor cells. We don't want those cancer cells to repair themselves and continue to grow and progress. So heating up that chemotherapy drug will have an impact in that way as well. Why do they give HIPEC intraoperatively instead of neoadjuvantly or adjuvantly? Well, because they're concerned when they do these debulking surgeries or any surgical procedure about adhesions or scar tissue that forms from the surgery. Those chemotherapy drugs get better perfusion throughout that peritoneal space if they do it at the time of surgery, because they don't have to compete with scar tissue, which is a little bit more fibrotic, a little bit more hardened. So if they do it at the time of surgery, there's not enough time for any scar tissue or adhesions to form. Patients with less extensive disease are less likely to have widespread microscopic disease after debulking. So the potential benefit of including HIPEC is less likely to outweigh the risks. So they don't tend to do HIPEC for patients who have lower stage of disease, because that HIPEC is really looking to treat some of those metastatic deposits and some of that peritoneal spread. And if they know that it's confined to the ovary, there are always some complications when they give any kind of medication. So they want to make sure that the benefits of giving HIPEC outweigh the risks. And I do have a last pop quiz, but I want to give us time to handle some of those questions that have come in. So I will leave you with that quiz to do on your own. And it has to do with surgery code. So if you're looking to practice surgical coding, I've got a couple of scenarios for you, and we won't go over it here, but you should have the answer in my slides. So that is the end of my presentation. And give me 1 second and we will transition into our Q&A period. And just another reminder to please go ahead and fill out the evaluation. I've got the link to the evaluation in our chat, and I will go ahead and post it one more time while we're doing the Q&A, but we really do value and appreciate your feedback. So if you could take a moment and fill out the evaluation for today, thank you in advance for doing that. I've got that in the chat right now, and let's see what other questions have come out. It looks like a lot of them are relating to that new data item, sex at birth. So Michelle, do you want to start with that? I can pull up the data item from the dictionary. I've got it up already.
So do I, Juliet. And actually, I would prefer to share my screen.
Oh,
And
absolutely.
let me put the link to what I'm looking at in the chat as well. And also, if possible, I was thinking it might be a good idea to talk about the ovarian questions first. And that way, anyone who wants to hop off and doesn't want to listen to me talk about this data item doesn't have to.
Sounds good.
Is that okay, or do you want me to go ahead and answer first?
Oh, no, I can answer first.
Okay.
So just add in if I'm missing any of the questions that have come up. So we've got one question about, is there any indication that COVID affected diagnosis of ovarian cancer? I am going to have to do a little bit more looking on this one. I do know that, interestingly enough, one of the presentations at NCRA last year covered the fact that stage 4 patients were still pretty commonly diagnosed. And a lot of these ovarian cancers present at later stages. So I'd have to do some more digging on that. So I will give you a more full answer when we do the Q&A document, but good question. Let's see. If a physician says ovarian cancer and the pathology says fallopian tube cancer, which outranks the other? Another great question. And you're going to want to look at the solid tumor rules because they actually do have a priority order for coding primary site. And you're going to want to follow that priority order. I will link to that in the chat. Hopefully, you're not going to find too many cases where there is a discrepancy between what the physician states and what the pathology report states. But do remember that depending on what tissue gets removed, the pathologist is only looking at the tissue that is actually submitted as a pathology specimen. The surgeon is actually getting to see all of the sites that may be involved. So look at the surgery report, look at the path report, and then follow the hierarchy for coding primary site. I think we also have it listed in our ACR supplements, but I'd have to find the exact page that that is listed on. So you should have access to how to code the priorities, the primary site based on priority order. Okay, next question. So I have found differing opinions on this. Pathology report says fallopian tube primary. Per the pathologist, when there is involvement of both fallopian tubes and ovaries, most GYNs and ONCs will just call all of this ovarian cancer. Should we code these per the SEER instructions as fallopian tube or go by the physician statement? Basically the same question. And I know in our supplements, we defer to, well, I'm not going to state this without actually looking, but we do have that priority order for you. And it's challenging. It is challenging sometimes to determine ovary versus fallopian tube when it comes to coding the primary site. Under surgery codes, if a female already had her uterus removed years prior for benign reasons, do you still use the surgical code that the hysterectomy is no longer there at the time of cancer removal? And then there's a SEER inquiry. Is this still correct? Well, let me look into that as well. I know that we are given instructions on how to code if that organ has already been removed. SEER really looks at the cumulative surgery. And so we're going to follow our instructions, the coding handbook. So I will have a more full answer of that so that I can give you page numbers in the appropriate manuals where you would go to look for that information. Good question, folks. I think that's all that I see for the ovary portion. Michelle, am I missing anything?
No, I think you got them all. Yeah, a lot of those look like we need to take a look at our resources and give a more detailed answer. So we'll have all of that for you when we issue our final Q&A document after all 4 sessions. So anybody who doesn't want to know about the new data item sex assigned at birth, you're welcome to hop off now. Everybody else, I'm going to share my screen, and if you all want to follow that link that I sent you to the NACER data dictionary, we're going to take a look at this together, okay? All right, give me a minute. Okay. Does everybody see my screen?
I
Juliet, can you
see
hear
it.
me? Okay. So do we see the version 26 of the NACER data item dictionary? Should say data item
We do.
225, sex assigned at birth. Okay. All right, guys. So a couple of the questions that we were looking at were kind of concerned about, and I think we might be spiraling a little bit with this new data item, especially because it's very different from what we normally do. And I also understand there's no 2026 version of the store available yet that I'm aware of. So all we really have to go off of are the notes that NACER is providing for us. So again, this is a new data item for 2026. It's associated with the patient, not the tumor. It's going to be required, and here, hopefully my scrolling is working correctly and you guys can see where I'm going, but it just says here that it's going to replace existing data item sex, which is data item number 220 for all cases, regardless of diagnosis year. And it also says that existing data in that current sex data item will be converted and used to populate the new data item. Now, it also gives us some general coding instructions. And I think a lot of the questions that were asked in our Q&A for this particular session are answered in these notes, okay? So number 1, it says, assign the sex of the patient assigned at birth. It says when the patient's sex is documented as male or female and there is no other information to indicate the patient was assigned a different sex at birth, assign 1 or 2. So one of the questions in the Q&A was asking, are doctors going to be required to say sex assigned at birth? That's not something I can speak to, but from what I'm reading in these general notes, you're going to assign sex as you normally do. So if the patient is documented as male or female and there's no contradicting information, you're going to assign male or female as usual. The only time you're going to have to use some new rules is when the sex is not known. So you can see in note 3, they're kind of trying to give you some helpful hints to assign that sex when literally when you do not know the sex of the patient, the sex of the patient is not listed. So you can assign male when it's certain primary sites that would only be found in male anatomy. Same thing, you can assign female when it's a primary site that's only associated with female anatomy. You would assign known for primary sites that are not included above when you do not know the sex. And then it says, note 4, I think, is where we're kind of getting a little mixed up here. So I kind of want to talk about this a little bit. So assign code 9 when sex is unknown, and that excludes when you've already run through note 3 above, okay, or not determined. And it says, do not assign code 9 when sex is documented as male or female, and there is no information about sex assigned at birth. So I'm hoping that this is kind of trying to show you that you're not going to run into too many instances where you're not able to determine the sex of the patient. I don't think we're really going to have that many unknowns. Also, it says assign code 9 if patient is born with disorders of sexual development and sex is not clearly defined. It says assign code 9 when patient sex is documented as other than male or female, example, non-binary, transsexual, and there's no additional information about sex assigned at birth. So again, you're going to be most likely just using note 2 before you head into any problems with coding the sex of the patient. So I'm hoping that when the store manual comes out, they'll have all of these coding instructions for you. But until then, I recommend following that link and reading up on this and kind of trying to understand what it's actually going to be and what it's not going to be. Because I don't think we're going to have that many instances where this is a problem. Now, that being said, if something comes up and you're trying to apply these coding instructions and you're still getting stuck, that's what Juliet and I are here for. So we're always happy to help you and answer questions if that should be the case. I'm going to stop my share so I can look and see. So again, Candy, I see your question. What about people who have both organs, whether so you're going to apply the notes and you're going to apply the rules. So you would be able to assign the sex of that patient based on the priority rules that are listed in those general notes in that data item that we were just looking at. Juliet, did I miss any other questions or statements that came in about that?
Not that I saw.
Okay. So anyone who isn't, okay, so Candy, another question. So anyone who isn't male or female gets lumped into unknown. Potentially, yes, but that's only when you've exhausted all your other resources in trying to assign male or female to that patient. And I know that's not ideal, but this is how we're going to be coding sex moving forward for 2026 forward. So. And if there's any further confusion, just shoot me an email. Like I said, I only really spoke about how the edit's going to be applied. It's only going to allow you the 3 allowable values. It's going to be 1, 2, or 9. So, you know, as we convert to V26 and we start running those new edits, if you guys are running into problems or have questions, you know, we're just an email away, okay? Okay, I don't see any other questions or chats. So I think we're
don't
okay.
either.
Okay.
I was just going to say we've got a while before 2026. So
Yeah.
by that point, I'm sure I'll be doing a presentation next year at our workshop about 2026 data collection changes, and Michelle will be talking about QA and all of that. So we'll cover it in more detail once we've seen what store ends up looking like, any updates that we get from our standard setters as they are looking into these new data items as well. So there's a long time.
Yeah, there's plenty of time, and you know, these notes might be clarified or expanded upon. You know, Cancer Forum and SearSync are always good resources if we have questions about that as well. So, I mean, we're not going to leave you in the dark about this, and any weird situation that comes up, you know that you can always reach out to us and we can either help you get clarity or we can help find that clarification for you as well.
Well, thank you all. Please fill out that evaluation, and we look forward to seeing you next week for session 3 of our workshop. Have a great week, everyone.